Hello everyone and welcome to this talk. It is with great pleasure that I briefly present our work on the integration of regional information in perfusion CT to improve the prediction of tissue outcome after stroke. Current methods for the detection of both necrotic tissue and tissue at risk mostly rely on voxel-wise thresholding. However, it is likely that the fates of neighboring tissue voxels are closely interdependent, as they share similar physiological characteristics such as vascular supply and/or collateral blood flow. Scalzo and colleagues have shown that in a small sample, two-dimensional image patches appear to be superior than threshold-based methods for Tmax. In this work, we aim to evaluate the impact of three-dimensional regional information around a given voxel of interest in the prediction of its tissue fate. To this aim, we construct a three-dimensional receptive field around this voxel to be predicted that contains all the voxels within a certain radius that we denote RF. The aggregated information is then processed via a general linear model. We evaluate different receptive field sizes to find an optimal solution. To train and evaluate our model, we collected the perfusion CT images and follow-up MRIs for all patients undergoing either intravenous treatment and/or endovascular treatment in 2016 and 2017 in our hospital. We excluded patients with no follow-up MRI within the 10 first days after stroke onset, as well as patients with major deformations or artifacts, as well as those with no lesion seen on imaging. This resulted in a total of 144 patients included. The perfusion parameters Tmax, CBF, CB, and MTT were obtained for all patients in the acute setting. The final lesion was then labeled on the follow-up MRI by an expert neurologist. The task for our model was thus to predict the segmentation of the final lesion based on information contained in the perfusion sequences obtained in the acute setting. To this aim, we trained and tested our model on this data with 5-fold cross-validation. Now, if we look at how the model performs on this data, this graph shows a model for every evaluated perfusion metric, shown here with the different color codes. The model's performance was evaluated in terms of area on the ROC curve, shown on the y-axis, for increasing sizes of three-dimensional receptive fields, as you can see here on the x-axis, starting at 0, so a voxel-wise prediction, and then increasing in a stepwise fashion up to a receptive field size of 5. For all evaluated models, performance increases when applying a receptive field, but then generally plateaus off. We can also see that Tmax, here in orange, is the single best performing metric, performing just as well or even better than a multiparametric model shown in green. A receptive field of size 3 was found to work best for all perfusion parameters. When comparing this with a voxel-wise model, this significantly increased the model's performance to predict the final tissue outcome, as we can see on this slide. For the prediction of a single subject with the multiparametric model, this would look something like this, where we have the ground truth segmentation shown on the leftmost image A, and on image B we can see the model predicting the lesion without the receptive fields. And we can see it produces scattered and less contrasted risk maps. However, when applying the receptive field, the prediction becomes more spatially coherent and is increasingly resistant to noise. We can also see in this example that increasing the size of the receptive field too much can in the end hurt performance, as we can see here in the rightmost image. This may be because very distant voxels of different vascular territories are included. To verify that the learned kernel was not just in effect basic weight averaging, we further benchmarked it against standardized perfusion maps and perfusion maps with 3D Gaussian smoothing, where the optimal smoothing was determined experimentally. We see here for Tmax that our model with receptive field remains significantly superior. So overall, we can say that integrating regional perfusion information through receptive fields can improve the prediction of the final lesion after stroke. And with this, I would like to thank you, and please do not hesitate to contact me if you have any questions.